During the first in the series, we talked about taking a highly therapeutic and safe treatment, in this case medical ozone, and innovating on medical ozone over the last 10 years or so, and why that was so important to deal with the current state of our global health, for example. But today, I want to take a different principle. I want to take the principle of taking a medical technology that everyone is aware of, in this case, ultrasound. Most of us have had an ultrasound procedure during our lifetime, and innovating on the ultrasound technique and using that technique to fill a gap in medicine. What is that gap? I, as an integrative doctor, and Dr. Mansour, as an integrative doctor, understand that there's a huge gap in pain management in allopathic medicine. We have our medicines, we have our drugs, our opiates. That led to the opiate crisis in the United States, but we don't have perfect control of our pain syndromes, our musculoskeletal pain syndromes in particular, our neurological pain syndromes. And then how do you take a technology like ultrasound and innovate into that and to take care of that particular problem? So Dr. Mansour has had mentors in this case in the field of using medical ultrasound to identify choke points in nerves that cause a great deal of pain. And this is called the emerging field of hydrodissection. And I wanted him to detail it today and talk about it, and then I can ask him specific questions. Go ahead, Dr. Mansour.
Sure. So a lot of common approaches to pain management involve injection therapy into the foresaid region of pain, with or without imaging. Oftentimes it's based on MRI imaging or X-ray imaging. Those are static forms of imaging that may or may not actually reflect what's generating pain in a patient. Without a proper physical exam, history, and prior diagnoses, it's very difficult to ascertain what actually is generating a patient's pain. Let's say, for example, in the lower back or in the hip. There are a variety of nerves and accessory nerves that innervate those areas, and not always does that translate to what's reported on an MRI. And that's a common misnomer in the field of pain management, is to rely heavily on those types of reporting. And I feel the emerging field now is to use a dynamic, real-time form of imaging, which is ultrasound. And with ultrasound, you can see tissues, you can see fascial planes, so the connective tissue planes that harbor veins, arteries, and nerves in real time and with motion. And you can actually induce temporarily an exacerbation of pain, which would be confirmatory diagnostically in terms of what is actually generating a patient's pain, which is seemingly a simple question, but often difficult or overlooked in terms of the potential triggers with standard imaging and standard diagnostic techniques.
So I just want to make this clear to everyone. Those of us that have had an MRI recently, remember that we cannot move during the entire MRI procedure. That's the whole problem with it. Even though it gives tremendous images, you cannot move. So I had a hydrodissection procedure, which you'll describe in a moment, where when I looked straightforwardly, I had no discomfort in my shoulders. But when Dr. Mansour pressed the probe onto a certain region, I could feel the pain, and he noted it, and that caused the diagnosis to be focused on one area versus another area. So it's the real-time motion that is one of the big innovations, but the other one is you have to be a master practitioner at this technology because you have to have a deep, deep understanding of anatomy. We were talking about musculoskeletal anatomy as the number one driver of whether you can use the technology to its maximum capability.
Absolutely. And not only understanding the various musculature in any given region, the fascial planes that separate the various muscles, and where choke points, as they're often called, can occur due to overuse or due to the simple leveraging points of muscles, and where their attachment points are on joints. The other big contributor to pain, obviously, is how to track and trace nerves that go through those muscles and go through those areas, because nerves are never moving in a straight line. They're always moving in and out of fascial planes, often associated with vasculature, blood vessels, nerves, arteries and veins. And the only way to really differentiate those tissues is with ultrasound. That is the gold standard now in terms of how to safely inject into a region that may have been a choke point for a nerve without hitting a blood vessel. There's really no other superior way of doing it without using ultrasound in a safe manner.
So, who in a normal hospital setting would normally be capable of analyzing a case in this particular way?
Generally speaking, orthopedists, orthopedic surgeons, to a certain extent, use ultrasound. However, they may or may not be using ultrasound continuously in their injection approach and how they actually go about injecting a certain joint or tissue or around a certain nerve. They may use ultrasound initially as a placeholder, as to find the appropriate landmarks, and then they may or may not use it continuously during their injection. And the added benefit of doing it with ultrasound is you know exactly where your needle tip is, you know exactly where the vasculature is, and you know where to avoid those vital structures in your approach.
So, can you explain the concept of the term called hydrodissection, what it means, and how it's used, and why that's different than when an orthopedist injects an anesthetic like lidocaine into your joint or into your muscle to reduce the pain?
Yeah, so hydrodissection, the term dissection is really an object that balloons or creates more space. And I'm sure, Dr. Herskowitz, you have far more experience in the realm of cardiology. What a dissection mean? It's actually a bad thing in that setting. In our setting, it's actually used to create more space around choke points of nerves, myofascial adhesions, so often connective tissue due to trauma or scars can adhese and create web-like projections that choke nerves as they pass through different muscle planes and different fascial planes. The only way to do and achieve hydrodissection is to use some sort of fluid to actually physically open up those planes and create space. Hence the term hydro, meaning some sort of fluid, dissection meaning creation of space. And if you do that in a targeted way, you can actually relieve irritation around a nerve or irritation in a muscle group and relieve those adhesions and open them up. The problem with a lot of manual therapies, chiropractic, physical therapy, is sometimes you can get temporary relief because they are momentarily relieving those adhesions, but if they are severe enough, you actually do need a manual form or a physical form of therapy that actually will open up those adhesions with fluid. And the only way to do that safely is through ultrasound-guided injections.
Right. And one of the other things that I've noticed during the procedures that you've performed here is that you can get immediate relief.
Yes, yes. It can be dramatic, especially no two people have the same anatomy. Um, Even in anatomy books, it's very misleading in terms of what the standard anatomy is. And various neck muscles, your scalene muscles can be very different between person to person. And that's often a place where nerves come in and out of. And what you typically find is once you understand that anatomical variation under ultrasound, you'll understand why a patient has been in pain for so many years and got relief suddenly just from one injection. And once you can image that and you see that in real time with motion, then you can understand, okay, this is what was causing your pain for so long, and it can oftentimes cause immediate relief.
So, Dr. Mansour, I want to move the discussion over to examples. So, for example, there are common examples like neck or lower back pain, shoulder pain, knee pain, hip pain, radiating pains of varying kinds, mystery pain for that matter. But there's also more esoteric things. As you know, we do take care of cancer patients, and cancer-related pain or tumor-related pain is extremely common and not well suited for anything but opiates, and that's unfortunate. And then there's also examples like migrainous headaches or chronic headache patients, which those types of folks suffer a great deal and don't have a lot of recourse. So why don't you speak to the whole issue of these types of examples that you've seen?
Yeah, I mean, to discuss something that's very prevalent as migraines, for example, could be derived from some of the choke points I've mentioned in the suboccipital region of the neck. So right at the base of the skull, there's a lot of nerves that kind of go through the super highway on the back of your neck at the base of your skull, and that can cause radiating pain up the head to the scalp. It can cause pain that's similar to TMJ, so it can be misdiagnosed as TMJ, and those could be subsidiary branches out of your C2 or the level of C2 nerve roots and C3 and the greater and lesser occipital nerves. So those are nerves that innervate the back of your head and go all the way up and can create like a question mark shape type radiation of pain. And a lot of choke points in that region at the base of the skull can be easily treated under ultrasound guidance and with a hydrodissection. But it really is important to have visualization because you also have the occipital artery there. You have
you have to have that,
yeah.
Of course. But how about, can you explain to the audience about the mechanism of most of the tumor-related pain syndromes?
Oh yeah, so a lot of conventional therapies using chemo, radiation, that causes residual scar tissue, and that scar tissue can definitely impair nerve function. It can also impair lymphatic drainage. So a common side effect of those treatments is lymphedema, so swelling of the legs, swelling of the arms, and oftentimes if you actually hydrodissect around the neurovasculature bundles that include the lymphatic channels, you can actually improve lymphatic drainage of your extremities, and that lymphedema can actually improve.
So I think you've seen cases of post-mastectomy patients have dramatic changes to their lymphedema after mastectomy, right?
Yeah, even after a series of injections on one procedure, they can see pretty significant results in reduction of that edema and that swelling within a few days. And I've seen that dramatically portrayed in the legs as well, cancer-related and non-cancer related too. And it can be unilateral, bilateral, and those changes are pretty significant for the patient.
But how about the more common things? Just neck and shoulder, back, and so on?
Yeah, I feel that some of the things that are commonly approached in the conventional pain management realm, let's say for lower back pain, that's a common one. It's the fascination and obsession about herniated discs, and that the disc is what's causing your pain, and that's what we need to address. And we need to do traction, we need to do distractions to help alleviate that disc herniation, or even do more invasive treatments like surgery, or even remove the disc, when oftentimes that's not what's actually causing the patient's pain. The accessory nerves that come off of those nerve roots and create pain around the small joint articulations in your lower back, those accessory nerves, medial branches that coming off of the nerve roots are often what's causing pain. And those are very well visualized with ultrasound and can be easily treated. And that's a common overlooked area for, let's say, lower back pain, for instance.
So one of the things that I wanted to finish this really informative fireside chat with is, one of the most common questions I get asked is, hey, if this is so good, how come I haven't heard about it before? And how come my doctor hasn't heard about it before? And I want to address that. That's an issue. The requirements here are, you need to be a master practitioner on the anatomy side. You need to have years of experience with needling, placing a needle in a specific location. You have to have the right equipment, because this is not a standard ultrasound device is not good enough. You need very high resolution ultrasound. And in the setting of academia, which is my prior world before I started Anatara Medicine, you need to train. So when I may be a master at cardiac echocardiography or cardiopulmonary echo and peripheral vascular echo and carotid echo, but I'm not capable of doing this procedure on my own. I need to have an expert with me, which we have access to, and we learn constantly from them. So as a fellow, for example, as someone in training in the hospital, it would take, I think, at least a full year of training before I would let someone do a procedure like this on their own. So it takes a lot of effort, a lot of time, and that's why you haven't heard about it. And that's why only a few anesthesiologists and a few orthopedics people and a few chiropractors actually are experts in this, and a few interventional radiologists, but it's not widely available. And I'm proud to say that we now have it available at Anatara Medicine, because it fills a deep gap in our portfolio of things that we have in the toolbox. So I want to thank you, Dr. Mansour, for your time today. I want to thank everyone for your time. Take care. Bye-bye.